So, in the previous lecture, we talked about the history and the progression of psychopathology and how we have treated mental illness. And where we left was the focus on severe psychopathology. Even today, you might have a short term hospitalization with aftercare, with a focus of setting people up in the community. But the vast majority of people today do not need to be hospitalized, right? We typically focus on talk therapy or psychotherapy, and most people can benefit from private psychotherapy. And what we've seen is private psychotherapy is you schedule individual sessions with the clinician, and you usually meet once a week, whether it be 45 minutes or an hour or 50 minutes. Each clinician will have their own time frame, but you set up weekly sessions and you go there. Now, historically, private psychotherapy, the person paid out of pocket. And I think that's important to note that before the 1950s, psychotherapy was, more accessible to middle to upper class individuals. And you could be in psychotherapy for however long you wanted to be in, as long as you could pay for it. One of the interesting shifts that took place is since the 1950s, there has been a lot more focus on managed care. And the vast majority of people today utilize their health insurance as a way of paying for psychotherapy. So having health insurance increases access to treatment. Now, does that mean every clinician today takes insurance? I'll tell you the answer is no. Some clinicians still remain as private pay, fee for service model, but many people do get on panels. So I would say that roughly 75% of people who receive care, they use their insurance for that. Now, other areas in addition to individual psychotherapy, you might see people using community mental health centers. And we talked in a previous lecture that community mental health centers are underutilized and there aren't enough in the community. So community mental health centers alone are not enough. And one of the biggest criticism is that, especially in lower income communities, community mental health centers are hard to find. So it creates a barrier because individuals might have to travel at a greater distance using a car service or a bus or whatever, a train, whatever model they are using. Since COVID, there have been more online telemental health sessions. It has blossomed, and we have discovered that it is a meaningful way to engage in psychotherapy. So, one of the ways we are filling the gap of the lack of access due to community mental health centers is virtual telehealth or telemental health. There are other places where if a person is not in therapy, there are crisis hotlines, and there are crisis hotlines for everything, whether it be related to substances of abuse, you can call a hotline, whether it be related to having a panic disorder, whether it be related to suicidal ideations, whether it be related to victimization. If you can think of it, there is a crisis hotline for that condition virtually. So people are utilizing hotlines, and we do see the rates of utilization of hotlines have increased. especially post-COVID as well. Now, some conditions will require family therapy. So if we are working with children and adolescents, especially, we don't conceptualize the problem as just uh, an issue with the child. There might be issues surrounding the family and the family dynamics. So we might recommend family therapy to help with, family communication, power struggles, things of that nature. Um, we also have substance abuse counseling, which is its own model. Not everyone feels comfortable engaging in substance abuse counseling because there is a strong relapse rate. There is a stronger risk for legal engagement. So you might have to testify before the court, or someone might be court mandated, um, and so forth. There are a lot of reasons why some people don't engage in substance abuse counseling, but there are people like myself who are trained to do so, and we feel comfortable navigating relapse. We feel comfortable navigating fractured families, legal involvement, and so forth. And we see that roughly 1 out of every 5 adults are seeking and receiving some level of mental health care. So another focus is not just treating the problem once someone comes into the treatment room. There has been a movement towards prevention models. And I'm going to introduce to you 3 types of prevention. There's something called primary prevention, secondary prevention, and tertiary prevention. Primary prevention is when we develop a program which is designed to avoid the problem altogether. So if I can create a program that makes you less likely to develop a problem, that would be primary prevention. And the example that I like to give for primary prevention is the concept of the DARE program, drug abuse resistance education. More often than not, if a person has had DARE, it's usually in elementary school where some member of law enforcement comes in and talks about the effects of using drugs on the body as well as the legal cost. And then there's a focus on teaching people how to resist peer pressure. So the reason why DARE is given in elementary school is we assume the vast majority of kids are not already engaging in drug abuse. So if we can target the issue of drug abuse before it occurs, then these children are going to be less likely to engage in drugs of abuse. Now, secondary prevention is a model of treatment or a program that's created to address an issue in its early stages. So, for example, many people have sex ed in middle school or high school. And the assumption is that people are in adolescence are going to start engaging in sexual activity. So why not wrap into a health class or a formal class a discussion about healthy sex practices? And it isn't just the earliest model, which is the abstinence model. You might have heard the only safe sex is abstinence or self-sex, right? But in reality, that model, most people are ignoring. So people are going to engage in sexual practices. So sex ed, what they do is they teach people how to engage in safer sex practices, how to avoid unplanned pregnancies, sexually transmitted illnesses, and so forth, right? And as I said, this is secondary prevention because this happens usually right at the beginning when people are starting to experiment with sexual activity. Not before, but in the early stages. And the final one is tertiary prevention. And then tertiary prevention, this is what we're more familiar with, addressing a problem after it exists. So there are programs that deal with a problem that is really become a significant issue. And the example of tertiary prevention that I like to use are the 12-step programs. So we talked about substance abuse, and most people aren't going into a 12-step program until they hit rock bottom, until there's this significant problem that emerges that they're faced with or they have to address. So 12-step programs are usually designed for people who have engaged in long-term substance abuse, hit rock bottom, and are trying to rebuild their life. So you can see there are stages of prevention models. Primary prevention, let's address the issue before it develops. Secondary prevention, let's address the issue in its early stages so it doesn't become a chronic problem. And then tertiary prevention is we still have to create programs that are designed to address a problem after it does become a larger scale issue. So that's prevention models. Now, one of the things that we do with our programs is we try and understand what social factors are associated with the development of this condition. So if we were to go back to the DARE model, one of the biggest factors linked to substance abuse is peer pressure. And an element of the DARE program is to teach people how to push back or how to avoid the peer pressure. So we want to address social conditions that might cause some kind of psychological problem. We also want to be able to use some health data to be able to identify those people are at higher risk of developing a condition. So if we were to talk about the opiate epidemic and the concept of OxyContin, and there's a really interesting documentary on Netflix going on right now. But the profile is a person who had a significant health-related injury, and the doctors prescribed a larger amount of pills than the person needed. And then that person got hooked on it. For example, there might have been a time where you had a dental surgery and you would come out with 2 weeks supply of OxyContin. That shouldn't be, right? Because with a dental surgery, you might have a day of pain or discomfort. And then the next day you're already on the mend healing. So we saw that doctors were being encouraged to push OxyContin and to provide more and more. Well, we now have discussions and programs that address pain, other models to address pain other than giving pain pills. So that's an example of identifying those who might be at greater risk of a discussion. Now, we also see that historically, we focused on psychopathology. We focus on the illness as it manifests, not focusing on wellness. So one of the cool things about prevention models is that we are actually focusing on wellness. And it blossoms with the concept of positive psychology, which is focusing on positive attributes, feelings, traits, abilities, unique strengths. These factors are helpful in preventing disorders. So, for example, one attribute that's linked to positive psychology is creativity. So we might ask, well, how can we harness a person's creativity to create some resilience, so they're less likely to engage in some kind of pathology. So that's another aspect of prevention models. So another concept we have to understand is the concept of multicultural psychology. If you were to go back to the early history of mental health treatment, you will have a very skewed European, typically white European middle class model of treatment. And what multicultural psychology focuses on is that we start to focus on the uniqueness of the individual and some of their identity characteristics that might impact treatment. And our interest in multicultural psychology has been around for a while. In fact, some of the early identity development models come in the 1970s related to ethnicity. So the focus on multiculturalism is not a new phenomenon. Now, you might hear the concept of DEI, diversity, equity, and inclusion. That has developed and grown in, I want to say, the last 5 years in a significant way. But our interest on culture, our interest on the role race, ethnicity, gender, and whatnot impact one's development, impact the development of a mental health factor, impact treatment models. We've been looking at this since the 1970s in a meaningful way. And that makes sense when you think about it, because if you look at the history of race relations, pre-integration, the goal was fighting for equality, fighting for equal opportunity, whether it be related to housing, whether it be related to voting, whether it be related to being able to eat in the same restaurant. These factors are paramount. Then we start to see a lot of civil rights bills happening in the 1960s related to employment, related to housing, related to other civil rights factors. So by the end of the 1960s, we start to shift as to, okay, now how do we optimize health? So we start to look at the uniqueness of the individual as it relates to various cultural factors. Now, we are much better today in our understanding of cultural identity and multicultural psychology than we were, I want to say, in the 1970s. The earliest models of multicultural counseling focused on one aspect of the individual's identity. And now we have an understanding that one's identity is multifaceted. And in reality, a person has several identities. We have an identity related to gender, we have an identity related to race, we have an identity related to religion, we have an identity related to sexual orientation, and so forth. But in order to fully appreciate or understand the uniqueness of the individual, we have to really understand all identity factors. So in the 1990s, there was more of a discussion of intersectionality, which is how does how do the overlapping identity factors impact a person in society? So we've come a long way. I don't think we're fully there. We still have a lot that we need to work on as a professional society, but I wanted to give you a little bit of flavor that we don't and cannot treat all clinicians the same way. There is not a one size fits all approach. We have to evaluate the effect of culture. And we see that there's been more of an emphasis in the United States, and we pay attention to how certain individuals are more prone to various disorders due to external stressors. So we talked about multiculturalism. Another thing, as I said, outpatient care in the 1950s was all private pay. And I said there was a shift that happened for outpatient care towards insurance. And I mentioned that about 75% of people use their insurance for psychotherapy services. Now, this is what we talk about as a managed care model. An insurance company has the right to determine who you can go to, right? So, who is in network, has the right to determine the cost of each session, how much they're going to reimburse, and the number of sessions a client can have without reapplying for more sessions. And while insurance has helped in general increase access to care, managed care models are not without their own problems. We do see that there are some healthcare programs that will do what's called a clawback. They are constantly trying to reclaim money that they've paid out. There are battles to get a client to have services and so forth. I'll share with you one story. When I was an intern at the Hamilton Madison House, I was given a couple clients that were on someone else's caseload. And one of the clients I was given was a client who was diagnosed with dysthymic disorder, which we now call persistent depressive disorder. And this client had been at the agency for about 10 years. And I received the client because the therapist of record went out on maternity leave. So I'm working with this person. And then I get a notice that they are running out of sessions that the insurance will allow. And I am meant to file an application, which is standard, to grant them more sessions. So I did. And I got a letter back that this client is not going to be granted more sessions because they are receiving suboptimal care and they are not making meaningful gains. So that is an example of an insurance company saying, we're not going to give you any more sessions. Now, I just received this client. So I hadn't been working with the client for the 10 years that they were at the agency. So I called up the insurance carrier and I said, well, what do you mean suboptimal care? And what do you mean that they're not making meaningful gains? So I spoke to the person at the insurance company and they said, well, they've been at your clinic for 10 years. And that's an easy thing to address. I said, sir, are you a clinician by any chance? And they said, no. So I said, as a clinician, I want to explain to you the concept of dysthymic disorder. Dysthymia is a long-term chronic depressive experience. The person is going to have this condition for 2 or more years, and they're going to have lower levels of severity, but they're going to struggle day to day. So the very definition of the disorder implies that this person has a long-term battle. We know, and our goal is to help this person not further decompensate into a major depressive disorder or into a more severe version of depression. So the suggestion that they're not making meaningful gains, that assumption is wrong. And then I asked, well, what did you mean they're receiving suboptimal care? And the insurance company said, well, we are reviewing their medical record and we see that they're on such a dose of antidepressant medication, and our medical team thinks that their medication should be twice the dose. And the prescriber is giving half the dose than is recommended. And I didn't know how to respond to this. I said, well, listen, I'm not the person prescribing medication, but if you give me a brief hold, I will speak with our medical director. And I spoke with our medical director, and he said to me, did you tell them that the client is an Asian American and that Asian Americans typically respond to lower doses of medication than other ethnic groups? So I get back on the phone and I said, I spoke to our medical director and he explained why they're on this dose. And there is a legitimate reason. So now that I've addressed both of your reasons for not granting more services, I'd like to request an additional 10 sessions with the client. And in a huff, the person said, fine, we'll do that, but within the next 2 sessions, you have to have a new full medical evaluation. And I share this story with you because that should not be. If a person has a mental health condition and they need services, the insurance company, although they have the right to determine how many sessions you can work with a client, many times this results in gaps in care. And if I didn't fight for my client, they would have had to leave the agency and they would not have maintained their therapeutic connection. And that's not right. So I will tell you, keep an eye on that because you can push back on insurance companies. They have a business model where they're trying to save money as much as possible. Another issue we see is that when people are engaged in managed care, they usually get paid, or the clinician gets paid less than when a person's not in managed care. And psychologists, as well as other mental health providers, have been fighting that mental health treatment should be reimbursed at the same rate as other medical problems. And this is what we call parity laws. Now, have we won this battle? The answer is no. We're still fighting. Some insurance companies are better than others. I usually don't mention names of insurance companies, but I will mention one that's pretty good, and that's Aetna. Aetna seems to be willing to price similar to what a person would get paid in private practice, but not every insurance company operates that way. So we fight for parity. We fight for equal pay. So that's the prism there about parity and managed care. I also want to introduce you to, and we're going to have a lecture in lecture 3 on all of this, but there are different models of treatment. And when we refer to a theoretical model is a framework by which you look at something. And when we say a theoretical model for mental illness, that is the framework by which you believe this mental illness originates. And we have many theoretical models or orientations, such as the psychoanalytic, biological, behavioral, cognitive, humanistic, existential, sociocultural, and so forth. There are a lot of them. And there is no single model that explains everything. So if you were to say, well, I only want to look at things through the lens of biology, you're going to miss a lot. So we usually integrate multiple models in our conceptualization of mental illness. And we'll talk more about this in a future lecture, but that's our starting point. Now, who is doing the mental health work? Well, we see that psychologists are not the only individuals providing mental health treatment. We have psychiatrists. Psychiatrists are medical doctors. They go to medical school. And in addition to providing therapy, they can also prescribe medication. Whereas clinical psychologists, counseling psychologists, and school psychologists, these are typically doctoral level professions, but you're not going to medical school. And because you're not going to medical school, outside of 6 states, you're not going to be prescribing medication. What you are going to be doing is focusing on the therapeutic interventions. So talk therapy, whether it be individual therapy, group therapy, couples therapy, and so forth. Now, you might ask yourself, what is the difference between a clinical, counseling, and school psychologist? A clinical psychologist is trained to deal with the widest range of psychopathology. So the most extreme of mental health conditions, if you are a clinical psychologist, you're trained to deal with that. Whereas counseling psychologists, sometimes they're trained exactly like clinical psychologists, but sometimes they're meant to treat relational stuff. So a counseling psychologist might focus more on family work or romantic relations and so forth. School psychologists, they're the focus of training. Again, school psychologists can be trained the same as clinical psychologists, but the focus are school-related conditions, things like ADHD, things like oppositional defiant disorder, and so forth. So each one of the psychologists, if you go to a training program, you can expect to be trained for certain conditions. Now, you'll notice that I said that clinical counseling and school psychologists can be trained the same way. And at the doctoral level, there are fairly uniform guidelines as to what courses you're required to take. And state licensure laws at the doctoral level rarely distinguish between clinical counseling and school psychologists. Now, a school psychologist, you can be licensed at the doctoral level, but you can also be a certified school psychologist who's licensed at the master's level. And that's part of our picture too. So we talked about psychiatrists, which are typically viewed as the top of the food chain. Then we talked about doctoral level psychologists and then master's level psychologists. But even so, there are more, sorry, they're doing gardening outside. Even so, there are other professions that are part of the treatment model. For example, there are psychiatric nurses and psychiatric nurse practitioners who play a role. Newer professions that have been wrapped into this are marriage and family therapists, mental health counselors, and social workers. And this is just, a picture of all of us who oftentimes work together to provide mental health care. Now, if you were to look at the various, if you want to look at the various degrees, you will see psychiatrists. Psychiatry has been around the longest. You will see that psychiatrists on average get paid the most. But you'll also see that it's skewed pretty male. Whereas the other professions, psychology, social work, mental health counselors, they're later professions and they skew more female. Now, I did get a question in the chat, and the person said, I am a pre-med student and planning to go to medical school. I would really appreciate if you could share me a chart of medications for some of the cases you have them. So the good news to the person that said that is each of the conditions, we're going to talk about treatment models, and we will talk about different medications that work. So we will cover some of this. Now, in all fairness, this is not a course that's designed to prepare you for medical school. So you aren't going to get the same level of coverage as you might get if you took a pharmacology course or program. But there will be coverage for each of the conditions and common medications. So I will certainly address that. All right. So let's also try and discuss how we use research. Today, there is a strong emphasis on what's called evidence-based practice. And evidence-based practice is if I'm going to do a therapeutic intervention for you, I need to know that this intervention has been substantiated by research. So one of the really cool thing that's going on is something called clinical research, where there are researchers trying to understand every single psychological disorder, try and understand what some of the risk factors are, the origins of the conditions are, predictive factors of the development of a condition, and trying to understand which treatment models are most effective. So you will see more and more manualized treatments and evidence-based practices as we progress. Now, the last thing that I want to talk to you about is how we are now harnessing technology. We are now using what's called telehealth or telemental health. And post-COVID, it's become pretty popular. But even prior to COVID and 2020, we have been engaging in telehealth for a while. And there are guidelines to effective care for cyber therapy. And what we found is telemental health can be equally effective as going to the physical treatment room. And there are clinicians who use Skype, Zoom, and a whole host of other HIPAA-compliant apps to engage in telehealth. As I said, the biggest benefit of cyber therapy is that we can fill in gaps. For example, cyber therapy is quite useful in rural communities where there might be 2 or 3 physical locations where you could get therapy, and there aren't enough clinicians. Well, with cyber therapy, as long as the person's licensed in that state, they could be anywhere. So, for example, I'm licensed in New York, New Jersey, and Connecticut. So if I want to provide therapy, I can provide therapy while sitting in my home in New Jersey to a person in Connecticut without them having to drive to my office. And that's a big deal. So for rural communities, it's pretty big. For mental health deserts, it's pretty big. I have a colleague who uses cyber therapy to maintain familial bonds for individuals who are incarcerated. So if a person's incarcerated and you want to do a family therapy session, you can use cyber therapy for that purpose and so forth. So we're seeing more and more shift towards harnessing technology for the treatment of mental illness. So that is our lecture. And I know that this was a shorter lecture because we plowed through it pretty quickly on the first half. Before I stop the recording, does anyone have any questions about today's lesson? Feel free to raise your hand when I'm lecturing. You don't have to wait to ask your question, but I do want to give you an opportunity at this point to ask if you have any. All right, so let me stop the recording here and I will take attendance afterwards. Now, I do have something in the chat. Give me 1 second before I do that. Virtual care sometimes could be a problem, especially if the patient didn't have a place to stay or being in a safe or private place for the treatment to be effective. That's right, George, that's a good point, that telemental health is designed to increase access to care. It does not mean that it's meant to replace traditional therapy models. So if a person is in a house where they have no privacy, and they want to talk about issues that's going on in the house, they might not feel safe to talk about it because they don't have privacy. That's a very good point. I have one client currently that I'm doing telehealth with who goes out to his car to do our session so that he's not in his home and talking about certain issues. But yeah, privacy is an issue. I would say that comfortability with technology is another issue. So there are other issues when we do use telehealth. It's not meant to be the only approach to doing therapy. So good point. Any other thoughts, questions, comments? All right, so let me stop the recording and then I'll take attendance again.